أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إنا أنزلناه في ليلة القدر وما أدراك ما ليلة القدر ليلة القدر خير من ألف الشهر تنزل الملائكة والروح فيها بإذن ربهم من كل أمر سلام هي حتى مطلع الفجر صدق الله العظيم.
Jazakallah. So before proceeding to formally starting this meeting, I will like to remember and pray for our legends that recently departed, especially my teacher, Professor Dr. Saeed Minar Saab, Professor Dr. Yunus Umro Saab, and also for the prayer for the soul Saab, Professor Z.K. Qazi Saab, Professor Suleiman Saab, and Professor Idris Saab. So please recite Surah Fatiha and 3 Qurs for them, and then Mr. Zakaria will lead the prayer. Thank you.
اللهم صل على
Also, Professor Mujahid Humail left us recently, so please keep him in your prayers as well. And now I shall invite Professor Dr. Zulfikar Ali Chumro Saab for welcome address.
نحمده ونصلي على رسول الكريم أما بعد أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين. Our welcome, respected guests, faculty members, and postgraduate students. Assalamu alaikum. I am delighted to welcome you all today at the 6th Bi-Monthly Regional Orthopedic Clinical Conference. I warmly welcome all of you at Ghulam Anwar Medical College, Sakkar. Today I am happy that we are resuming this great academic tradition started and paused by our visionary teacher and teacher of the teacher and great academician, Professor Dr. Asadullah Amar. Again, after the long pause due to COVID pending and Sakkar is hosting this event, I am great thankful to Professor Zamil Sumro and teammate coordinate and to start this regional orthopedic meeting first at Sakkar. This meeting is also special as we have honored to have one of the greatest orthoplasty surgeon of the Pakistan, Professor Dr. Syed Shahnur, who has graced the occasion with his team. It is a great also in some illness. Dr. Farooq Mahmoodi also is a congratulation. He will come, and now I talk on telephone. He will not come. It is also congratulations to Vice President Sindh of the POA Pakistan. I use this opportunity congratulate our patron, Professor Dr. Asadullah Amar, for his victory as Secretary General POA Pakistan. Again, It is a matter of the pride as a Pakistani orthopedic surgeon to congratulate Professor Dr. Syed Shahnoor for his election as President Asia Pacific Orthoplasty Forum. And also, I like to extend my warm congratulations to my brotherly colleague and dynamic fellow, Professor Dr. Zamir Ahmad Sumro, for his election as President Assami, Pakistan. I am thankful for all the guests who have spared their precious time to be with us today, especially Professor Dr. Shahid Noor, Professor Dr. Asadul Ahmad, Professor Dr. Jagdish Kumar, Chairman of the Orthopedic, our Sheikh Mohtama Benazir Bhutto University, Larkana, Professor Dr. Zamir Ahmad Sumro, Dr. Kazim Rahim is my colleague, is my senior colleague, come from Dhaka National, Dr. Sohail Akhtar Jokyo Saab, Dr. Badruddin Sato, HOD Orthopedic Do University, Dr. Nasir Ahmad, Dr. Mahmood Askari from LNH, Dr. Noman Saab, Dr. Ikram Mahmood Rajput from Do, Dr. Nazar Singh Shah, Dr. Anwar Wadan Saab, Dr. Shaib Jandio, and also Dr. Saifullah Sumro, Dr. Shahjan Sial, Dr. Rashid Sumro, Dr. Asif, and last not least, but Mr. Sahat is a good coordinator with through the web from the Pakistan Orthopedic Association, and also great thankful Hilton Pharma to arrange this event. Thank you, welcome. I wish you have a great academic session. Thank you.
Thank you, sir. Now I invite our first presenter and for his case of shoulder swelling, Dr. Ali Mohammad Bhutto from GMC sector.
Assalamu alaikum. I welcome you all on behalf of our department in regional disease. We are presenting our first case. A 22-year-old laborer, Shakil Ahmed, resident of Taqibul Amshar, came to OPD with complaint of left shoulder pain, which was throbbing and gradual onset, and it was more at the night. And it was associated with swelling at the left shoulder, which was progressively increasing in size for 1 month. And part 60 was insignificant, and he belongs to 4th class family, and there was not significant transphenoidal history. And on general physical examination, vitals and subvitals were normal, and there was no any sign over the systemic examination or any associated illness. On local examination, there was swelling around 5 to 6 centimeter at the left shoulder, which was firm to hard in consistency, and temperature was calm, and there was tenderness over there, which was localized to the proximal bone, not fixed to the skin or underlying any structure. And there was distal neurovascular was intact. On basis of history and examination, what would be the differential diagnosis? Few comments from audience. A 22-year-old male with history of swelling or the left shoulder. X-rays. This is a well-defined osteolytic lesion involving the proximal humerus and subchondral area with the cortical break and there was no periosteal reaction. This is it. Yes, sir. Yes. Yes.
Everything almost disappears.
Well defined, rather ill defined.
End of margins,
There is no margin.
cortical. Yes.
Yes, even few separations within inside the lesion.
Yes.
But it's also extending to some of the more of the acronym.
Chromium a bit spare.
The neck of his scapula is also not visible.
Yeah, that means it's not clear.
Is there any view?
Other no.
Through the MRI.
Sir, MRI.
Is a second tumor that is extending even to the proximally to the glenoid and the body of the scapula.
Yes, sir. Sir, MRI was done, which defined there is eccentric subparticular expansile large osteolytic lesion involving the metaphysioepiphyseal area with the cortical break. MRI picture.
Because you want to see either the joint is spared.
It's spared.
अगर आप निकाल लगाते हैं ना तो वो ग्रेनाइट बिल्कुल क्लियर रहती है.
जी.
You can see all the scapula.
Yes.
You want to plan something for surgery.
Yes.
You want to save the limb and you need to have an idea how many you can do the thing. So that will give you clear idea how many the bone left and which procedure you can do. So that's why you need at least put some X-ray and pictures of MRI. Before that will give you clear idea.
So we plan for biopsy after MRI, which shows the left proximal humerus with giant cell tumor.
Okay, so what is your plan?
Sir, our plan was to resect the tumor, wide margin excision with reconstruction.
Before when they
Before doing,
Yes, sir.
before doing aggressively,
Aggressive.
you like to start of the
Has a immunotherapy.
chemotherapy, addressing the tumor size, prevent the recurrence.
Yes, sir. This is after immunotherapy.
this is the denosumab.
Denosumab, sir. Just completed denosumab. This the
It's basically response some of our response
it inhibits the osteolytic activity.
with some different way of functioning.
Yes.
It is a response.
Yes.
It's not an immunotherapy. Just can use as a neoadjuvant
Neoadjuvant.
or the infection.
Yes.
It's not an immunotherapy. Immunotherapy is something different.
Come.
And
So-
apart from it, as it is aggressively, you need to have a workup for better. Also, because
Yes, sir. CT was done. Sir.
chances better, because aggressively and you have
Sir, CT abdomen and other was done.
you have to proceed for secondary workup.
Sir, it is isolated pathology where the metastasis was excluded.
How many doses you have?
Sir, it has completed 4 doses.
So see how excellent it is.
Yes.
Now all the tumor get calcified.
Yes.
Now your granite is clearly visible.
Yes.
The layer we are suspecting into the acromen is absolutely normal.
Yes.
So you have only tumor left inside this.
Proximal humerus. Yes.
That's all. So you need only to respect the solid. And one more thing, I don't know whether the biopsy was taken, and the trial was involved or not. So you have, if you MRI, you will have clear idea of the deltoid. Because you need to spare the deltoid. Once deltoid is spared, you will your function will be spared as well. So key to see in MRI to see the deltoid function. That is intact, that will give you a good idea for reconstruction. Because all the classification related to the proximal humerus resection depend upon deltoid. Plus minus you want to resect or not to resect.
No. Up.
Can I come there?
Yes.
चला नो Now if you see this acromioclavicular joint, this is acromion. So it's all is paired. You see the glenoid is spared here. Now you have proximal humerus only. See the deltoid shadow still if you see, so somehow it's also spared as well. Now this is beauty of denosumab before doing any surgery. Because if you now if you operate on this, you don't have a clear-cut idea where to operate and which margin you will take. Now you don't have a clear-cut idea of this glenoid, neither this acromion, neither in the proximal humerus as well. And there's no clear idea about the deltoid as well. So if you give the denosumab, that calcifies the tumor and becomes hard enough, that your dissection will be more easier. And there are very less chances that you will leave something inside the body. So you will be able to remove all the tumor easily. This is why you need to give the denosumab to make the tumor calcify and make your surgery resection easy. This is one message we can get from this. And second, what procedure we can do? There are too many options of reconstruction in the proximal humerus. You can do orthodesis, you can do replacement, you can leave with hanging shoulder, whatever you like, you can do. Now depend upon your resources what you want to do. So it's simple. If you can do, we can do resection with this by sparing the deltoid along with the axillary. Resect this, take the fibula, put here, and then orthodesis. This is one option. Number two option, you can put the same mega processes with reverse shoulder. You can put this glenoid here and along with this mega process of proximal humerus. So you can put reverse shoulder along with mega process proximal humerus. So this is second option. Third, sometimes people do leave as such and put this fiber from here and hang into the glenoid or into the acromion. But this somehow this big defect. So that will be not stable. Because key is to make this joint stable. So you need some movement at least 50 degree, 60 degree abduction, forward flexion extension. So two options are valid. Number one, orthodesis. Number two, you can do the replacement. So both options we can do. Yes. Yes, there is a third option. Okay, fourth one. There are too many other options as well. So you can do vascularized proximal fibula and then re-anastomosis because proximal fibula another blood supply, different blood supply than the mid-shaft. And then you do the anastomosis here with some axillary artery branch. And that head becomes slightly vascularized and that will give you impression that it looks to be a proximal humerus as well. So you can do this. So there are this yes, you can rotate this clavicle, detach from sternoclavicular joint, rotate it, put it here. Again, you need to put some plate. So that will be again vascularized graft as well. So these are all options of reconstruction around this.
For postgraduates, those appearing in exam, they will be asked what he will do, and they must know what is the standard approach to this, and they must must have full function and the workup of this arm and hand. Therefore, you must need to know that what is the standard. You have to reply with that, and then you will be asked, what will you do? There are many options, and therefore, for those who are appearing in exam, they must know the standard approach, which is very much well accepted, agreed by the whole community of orthopedic arena international. So modular or custom-made placement is the insert in that way.
So the sir said that see, the basic principle is important. History, examination, basic X-ray, MRI, CT chest. So exclude them because 5% of giant cell tumor can metastasis length. So exclude that. Once you're done with that, give 4 doses of denosumab with 0, 7, 15, and 28. So within 1 month, you will get all the results of calcification. Once you're done with that, then you plan for surgery. So this is basic protocol for following this giant cell tumor.
And also in exam, if you are saying that I am going to orthotics it, so you will be asked how is orthotics, what will be implant, and how will fix it.
Yes.
So you will be knowing these.
At least basic principles you should know. Thank you very much.
Thank you, sir.
Thank you.
Thank you, Dr. The next case that we have today is painful hip that will be presented by Dr. Ghulam Sarwar Sarki from CMC Ladkana. Area. मैं सब नहीं जो है देखिए बिहार पुलिस आनंद जो है
Bismillahirrahmanirrahim. Assalamu alaikum. Today is my case presentation. I am Dr. Ghulam Sarwar Sarki, postgraduate trainee from Shahid Benazir Bhutto Medical University, Ladkana. 22 years old female presented to OPD with complaint of pain in left hip region since 9 years in A 22-year-old female presented to OPD with complaint of pain at left hip region since 9 years, inability to bear weight on left lower limb since 1 year, leg length discrepancy and limping since 1 year. History of presenting complaint. According to my patient, she was all right 9 years back. Then she sustained road traffic accident and was diagnosed left neck of femur fracture. She was operated for that about 24 hours after trauma and fixed with a cannulated screw. Post-operative recovery was uneventful. She was allowed to partial weight bear after 6 weeks. After surgery, pain was not relieved and gradually increased in intensity and became severe for 1 year. Violinal score of pain is 8/10. Pain is localized to left hip on anterior side. Pain is aggravated by movement and decreased in intensity with medication. Take 2 analgesics 2 to 3 times a day. No association with fever. Patient is not able to bear weight on affected limb due to the severe pain. There is a limping gait and leg length discrepancy. Past history, she was operated 9 years back. Neck of femur fracture with cannulated hip screw. Since she has mild hip pain, which has been severe for 1 year. The drug history, she is taking NSAID 2 to 3 times a day due to the severe pain. Personal history: sleep is disturbed since few months due to the pain. Appetite also disturbed. No history of weight loss and addiction. But family history: she is unmarried. She has 5 brothers and 2 sisters. Mother and father are alive. Systematic review: insignificant. Functional deficit. Cannot walk independently. Walk very little distance with support. Cannot squat. Use commando chair near bed. General physical examination: female patient of average height and build, sitting on couch, inaccessibly well oriented, time, place, and person. Local examination: gait, cannot walk without support, cannot bear weight on left lower limb, movement of left hip joints are painful. There is flexion contracture about 40 degree. Muscle power: quads 4/5 and abductor 4/5. Sorry, video allow. Video allow. खाना में चलो ठीक है देखिए this is a video of patient. She is walking, difficulty in walking with limping gait. This is X-ray. This is a plain radiograph, AP and lateral view of the pelvis of skeletally mature patient, showing both hip joint with proximal femur. Positive finding were 2 cannula screws with washer present in left side of neck of femur. There is a decreased joint space and proximal migration of femur head, and there is multiple osteophytes with flattening of femoral head. This is the lab work. HB is 11.9 and WBC and ESR and CRP within normal limit. Urea, urine DR and urine culture with normal. Hepatitis B, C, HIV and COVID-19 is negative.
Discussion now.
Yes, sir. Summary: 22-year-old female, severe hip pain, left hip. Past history is neck of femur fracture and fixation was done.
Well, it is a case of fracture neck femur.
Yes, sir.
Vascular necrosis of femoral head,
Yes, sir.
and there's degenerative changes of hip as well.
Yes, sir.
So, and she is very much painful,
Yes, sir.
and she needs redo. Now, it matter go for operation.
Yes, sir.
So I would ask from those postgraduates, what can be done? My teacher professor, I know you when he was asking me when I was PG. So when I was silent to answer, you could say always say that mouse on foot as a cause of swelling. So you should say something. What to do?
There are multiple options.
It's a question from postgraduates. Want to ask how we can manage this patient. The 22-year-old female with severe hip pain and history of neck of femur fracture fixation. Any postgraduate who can tell about the options, how we can lead this patient.
And reduce the stone can also be an option that can be used in this marriage. Right, these are the options. What should be a standard option? That is the whole. And then THR can be.
Same movement. I am the resident. So I want to ask from the presenter, what is the flexion contractor and what is the adductor contractor? What is the examination?
Movements at the hip.
Is this fixed flexion deformity? Is this adductor fixed adductor contracted? Is there is contractor at the knee? First we exclude the contractors and then we plan our deformity correction. If we deformity, we do deformity correction, or we cannot save that in such a ankylosing. So we replace our other options. We take other options. First, we want to know what are the examination of this patient. How much contractures at hip, how much contracture at knee, and how much LLD in that discrepancy.
So, as far as the local examination is concerned, there was no contracture at the knee, but the range of motion at the hip joint was 40 to around 100. It was not ankylosed, there was the movement, but it was a little bit painful. So the movement at the left hip joint was 40 to 100 degrees, and it was observed during. It was not fully ankylosed.
I think a little bit of this patient, it's only depends upon the patient's desire. What the patient wants. If the patient wants a mobile pain 3 years, then you will ask for something else. And if the patient wants to live his homemade life with, and she is not anxious about the hip movement, then we can opt for the other option. So I think it's only depends upon the patient's desire, but the experts can tell that what can be done in this patient.
Obviously, whenever this kind of case is coming and in the exam, we have three options. We always tell whether we can do a resection arthroplasty, which is obviously girdle stone, or we can do a hip reconstruction osteotomy, or we can do a totally arthroplasty. Now, and we need to know obviously what would be the patient expectation. Patient expectation would be there that I should have an equal limb and that should move full range of motion as they should be doing. And she would also want a mobile knee as well. So if you want to fulfill those expectations of the patient, then obviously totally arthroplasty is the answer. Because those people who are doing HRO, they know that after HRO, it is not a simple procedure. First of all, the time it might take to complete that procedure maybe from 6 months to 1 year. The result is there, which actually have its own complication. And the patient might end up with only very hardly 90 degree flexion of the joint, and there might be contracture left and the knee joint as well. And if we are discussing about girdle stone, obviously the shortening of the limb in a 22-year-old female may lead to scoliosis of the spine and may lead to lumbar spondylosis later on. So the only problem with arthroplasty in the past was that obviously we put an implant in, then a race starts between a bit losing and the patient's failure. So the important thing is that if we want a good solution for that, we should select our implant and we should concentrate on our technique, obviously, which is another topic. But if I will have to answer in the exam, I will say that, sir, I will do a totally arthroplasty. And then obviously the next question, okay, if you want to do a totally arthroplasty, how will you do it? What implant will you use? What will be your bearing surfaces? That's how in the exam we can direct our examiner to ask the question and then your member will answer. I think you have done this case. It's completed. Yes. You can go ahead with the next step.
We discuss all options of treatment, their pros and cons with patient and her attendant. They decided for total hip replacement surgery. This is total hip replacement surgery.
This I had a little bit problem with the posterior wall. It was a little bit deep because the case was very old and very big osteophytes were all around the joint. So I reamed it and I made a trial. Trial was very good and placement and very stable. But before putting the actual implant, I put bone ground all around the posterior wall and all around the walls. Then I fitted the cup and it was very placement and stable. And added stability was provided by these two screws. So I would like to hand over mic to my senior.
I think plant looks very nicely and it's perfectly fitted with stem. Because obviously, Calcar is also very nicely at its place. The cup is also not included, photograph can be seen. Another thing which I can appreciate is that if I look at the, I don't know, maybe it's the problem of the X-ray, but if you see that we cannot appreciate the obturator fossa in the obturator foramen, you cannot see that. It means to take the APV of the head, the pelvis actually is tilted, right? And we can see the inlet view, which shows that whether this flexion contracture which was 40 degree, was it corrected or not?
Yes, it was corrected. Mashallah, today is the 6th post-op day. Patient is still in the ward. She is pain-free and she is mobile. I have kept it non-weight there for about 6 months. So, inshallah, in next meeting, I will show follow-up this.
Yeah. And what do you say of the residents? We should explain that what are the sequential releases for flexion contracture. As for the two releases for the knee, we should know how to release sequentially to release the flexion contracture of the knee. So how did you did that?
So I just put at the time of when I put the trial implant, I just checked all the movement. It was a little bit tight, so I just released a little bit of the helioswab. After that, the movement was very good, and all movement was possible. So I just released a little bit of the helioswab.
So this is very good for the residents. Obviously, when we are talking about flexion contraction and there is no adduction and abduction contraction, so it means that whatever structure are passing from the front of the hip are tight, right? So what are the structure which are passing from the front of the hip? Obviously, if we come from inside to outside, it would be contraction of the joint capsule. So we have to release the capsule from front. Then over the joint capsule comes the next muscle, which is rectus femoris. So reflected head of rectus femoris actually joins there, so we might have to release rectus femoris. Our facial letter might be tight, so we might have to do the slide, and then obviously the iliopsoas. When we are doing arthroplasty, we are actually starting with first we will release the iliopsoas, the capsule of the joint. We do the suture slide, and then we might release rectus femoris. If we are able to do that, most of the contraction of 30 to 40 degrees are mostly released. Thank you. That is very nice. The books are sequential release. Yeah, it's not getting corrected, then but obviously it's usually one thing, then you can move to the next structure and then you can move to usually at the 40 degree of hip flexion contracture is released spontaneously when you are cut the neck at standard cut. Sometimes after cutting the neck, you release the iliopsoas and you are looking wonderful inside vestibular. If you have a contracture more than 40 degrees, then you have to release early at the ear brim level. You release the superiorly the iliotibial muscles and rectus femoris. All these muscles are released from the iliac crest. If more than 40 degree flexion point, up to 40, you release only neck, cut the neck, and you release the iliopsoas. You are happy. First of all, I was from the leg, circular, and the Pratana team who have executed a total about. So this is not a simple primary total. It's the higher grade, the complex primary total replacement. So you are already elevating yourself from a primary total hip replacement to complex. What daily surgery did you use for this patient?
My time definitely ceramic, but there was the issue of affordability. It was done totally free of cost at government setup. So I went for the metal and wood.
I would advise, sincere advice to all participants, both faculty and that it is not mandatory to use cervical understand. If you look at the registry data, the most important component in the bearing surface is the poly and use highly cross-linked poly. Highly cross-linked poly are not expensive and you must ensure, I'll add one more thing, that the long-term result of ceramic on highly cross-linked poly and the result of metal on highly cross-linked poly are matchable. You getting my point?
Yes, sir.
So, if the cost is a constraint, the least you could do, because you've done a very good press with femoral component and thing, that you must make sure that thou shall not use an ordinary polyclinic. Make sure that you use a cross-linked poly. That's right. Thank you. Well done.
For beginners, as a general principle, the standard approach is that total hip replacement. And this is based on the, if there is major collapse here in ABN or there is associated osteoarthritis, then you go for total hip replacement. If it's an early stage, less collapse or no collapse, just ABN, even then, it's preferable to go for this total hip. If she is female, and the salvage procedure, you go for girdle discount. If young and liberal, you cash only, then the arthro disc. This is general principle of to the hip problems. Secondly, I will ask our senior and I will also learning, because in those days when I was postgraduate and left my teaching unit and came to Larsam. So what is survivorship of this total hip in a young patient, and it's simple, what is warranty or guarantee of it? How long it will work?
So, sir, I'll just take 2 minutes. The successful total hip replacement started in 1960 with Sir John Charlie, and he only did it for elderly patients. And he would not allow any surgeon to use his implant unless he comes to his center and he has a short training and certification. The results were very good in elderly patients. But then when the results were very good, we started increasing our indications of total arthroplasty during a younger. Younger hip pain, there was early failure. And early failure, people thought that it is because of cement disease. Cement is the culprit, is where they lose weight. So, a lot of North American people started manufacturing uncemented. To cut the long discussion in one line, there are 2 important things. One is the track record of an implant, registry data, 10 years survival, 20 years survival, and 25 years. आजकल जो अच्छे हैं, उनके 25 and 30 years survival के data. Femoral side पे अलग and acetabular side पे अलग. And third, bearing surgery. So your surgical technique has to be correct according to philosophy of the implant and use correct bearing surgery. मैं एक line और add करता हूँ. तो अच्छे uncemented femoral component and good track record acetabular component. Previously textbook में आपको 7.7 मिलेगा, लेकिन अब registry data के मुताबिक highly cross-linked poly with ceramic or highly cross-linked with metal or ceramicized metal. Metal होता है, उसके पास ceramic की liner होती है. इसके बहुत अच्छे रिजल्ट. But to add यूरोप में अगर चले जाएं, नॉर्वेजियन कंट्रीज में, they do cemented implant, फीमर की बात करो, उनकी femoral component के survival cemented and uncemented का exactly बराबर, but then you have to choose the implant. For example, femoral component जो exited type का है, जो कि double tapered है, conical है, उसके अंदर आपने centralizer लगाए हैं, and fourth generation cementing technique अगर आप इस्तेमाल करेंगे, तो उस femoral component के survival किसी भी uncemented के बराबर है, ये femoral side की बात है। Acetabular side में uncemented के survival better है compared to cemented component. तो acetabular side पे अगर हम uncemented लगा दें, and नीचे cemented या uncemented लगाएं, bearing surface अच्छा इस्तेमाल करें, तो 25 year survival का कोई problem नहीं। Obviously, elderly में 50 plus में ज़्यादा अच्छे रिजल्ट है, 50 के नीचे younger कहलाते हैं। तो younger है ना, automatically अगर simple भी तो वो complex में आ जाता है। Has to be done by experienced person so that there are no technical mistakes. Will be masterly. From starting, they will become teacher and trainer. And यही मेरी ख्वाहिश है कि एजेंट का कोई पेशेंट हमारा टारगेट हो कराची ना हो, उसको सर्विस यही मिले, ये मेरा ख्वाहिश है, ये मेरा ख्वाब है।
Thank you very much, sir. It was wonderful discussion on this case, and I hope our residents have learned a lot, even our consultants have learned a lot. So we are moving to the next case, and it is a case of non-union TBI will be presented by Dr. Ahmed Dada Lagari Saab, who is senior registrar at Ghulam Ahmad Medical College Center.
Bismillahirrahmanirrahim. I'm Dr. Ahmed Raza, and I'm working here senior registrar at GMC sector. And please change here are dedicated orthopedic faculty. So I'm very happy I have joined here since 2 years ago from Civil Hospital Karachi. So one of the reasons to join here, my professor, ex-professor Faratib Saab, he motivated me to join a very vigilant personality, Zulfikar Sundro Saab, and I joined here. So I never forget my orthopedic family, Civil Hospital, Dow University, Karachi, Professor Muratib Saab, who has made me very strong in academics. So I always remember them, and my primary mentors, may rest in peace, Minal Saab, and a living legend, Professor Anisuddin Bhatti Saab. They were my primary teacher in JPMC. So I'm presenting very simple case and neglected case. Patient name Majid Ali, age 30 years, labor by profession, resident of Sakkar, came in our GMC, OPD with history of RTA 7 months ago. He sustained a closed right leg injury, and he was also non-smoker. So his presenting complaint was like pain in right leg and unable to walk. he was bedridden since he got injury. So he got the RTSM mechanism was 5 versus 5, and he brought to private hospitals where he was seen by orthopedic surgeon. An X-ray was done, and there was a closed segmental fibula fracture. So they decided there a closed manipulation reduction and full cast POP, and the plan was made to treat this fracture conservatively. So here, a segmental tibia and simple fibula fracture. So you can appreciate this is the X-ray done when we open the plaster in our OP GMC, and you can see a gross osteopenia in all of the tibia and fibula and foot as well. So we removed the plaster to check the union, and the fracture at the fracture side, the movements were appreciable in medial lateral and anterior posterior direction. So it was labeled as a non-union. On examination, the skin was intact, no sign of infection, distal neuromuscular status was intact, range of motion at the knee joint and the hip were normal. So past medical and surgical history not significant. So here is the X-ray, which we get done when he presented to us in GMC OPD. So what could be the treatment management plan from postgraduates especially? 7 months has been done, has been passed. He was treated in the plaster, and treatment was made conservatively, and patient was bedridden since 7 months.
Multiple options. Number one, environmental training, transport expert training, and second option, docking thread, bone grafting.
What do you feel in 7 months intramedullary nail will be easy?
Expert training.
Nail is nail, you know.
Open nailing is possibility. Right now we're talking about closed nailing. You can do a mini open and closed and do it along there.
Okay, there's the option.
Docking thread, bone grafting, and also the fibula. Ring fixator.
Okay, nice option. So treatment was decided as open reduction internal fixation with distal tibial locking elsewhere and huge amount of cartilocancellous iliac bone graft and fibulectomy.
Option of ring fixator was discussed with the
Yes.
patient, and he refused, pass the result. So then we have taken option of reduction.
Actually, he went to many orthopedic surgeons. They offered him an external fixator, Ellis rope, in a compression mode, but he ran away from there and he refused for this. So we also gave him, offered him Ellis rope refixator. We have a big post expert in Ellis rope, so he refused for this. He had the first post-operative day, and we applied the L-shape from anterolateral approach, which huge amount of the cartilocancellous was dropped. And post-operative recovery was uneventful, and he was in a very close follow with on good antibiotics for 2 weeks. So here after 4 months, you can appreciate the callus is here at the fracture side, and also here you can see the callus here. And after 4 months, well-healed scar mark at iliac bone graft side, and the well-healed scar mark on the leg anterolateral and fibulectomy as well. So this is the video after 4 months. He is pain-free walking without the support, and he is doing his job. He can squat, You can sit with the cross leg. I'm showing in the next video. So here the follow-up again after 1 year. So you can see the callus is more than the next previous X-rays, and fibula is united fully. The follow-up after 1.5 years, almost tibia is united, and he's pain free, and osteopenia is very covered from all foot and the tibia and fibula as well. So he's walking after 1.5 years. Thank you. Any question?
There any shortening?
No, sir. Sorry, I did not mention it. There's no any short. But I asked him why you are limping. He has a little bit. He said, I used to tear my leg. I don't know. Like the patient.
Sir, the muscle weakness because the patient was already bedded. So definitely there is use like to might be because of this.
Yes.
We might have to work on the anti-gravity muscle that otherwise there will be any shortening because
No.
it is very well. Often there is an accident case and with a good follow-up of 1.5 years and you will achieve accident. Second, there are different treatment options, or there is different treatment options. You can put a name in this. With early weight bearing started is compared to play with bone graft and that you can put a laser rope with early weight bearing and alignment. The most important thing, the bed ridden. I don't think so. Bed ridden with the one leg fracture. The patient can mobilize with the crutches, with the walker on one leg also. So, yes, he is unable to get there on the second side. Second thing that we can appreciate there is a regional osteoporosis, there is some Staphylococcus syndrome on the foot and ankle region, and the narrowing of the tibio-talar joint. So, most important thing, the physiotherapy role post-op. So, the patient having a lurch due to ankle, not due to hip. So you start physiotherapy from the first day of your surgery. We have protocol. I think put a good food supplements, calcium, vitamin D, all these things, and I think it's a very good case, excellent case. Congratulations.
तो शायद हम ये केस ना करते इसमें हम शायद लॉकिंग प्लेट और बोन ग्राफ्ट ना रखते. We have factors for postgraduate. We have a good factor from the patient. He was not smoker, and the injury was closed. Thank you very much.
Ahmed, it was nicely done. It was not simple. Because if you get myelinated trachea, after 8 months, it is not that simple to operate it. It's excellently done. Because if you achieve the union in this myelinated, that's rightly done, you did the bibliotomy already. The arterial ability to put some pain and reduction. And this is one side, if you see only is a very limited area. If you go on the middle side and put the plate again, just to clear it. So it was a nice decision to put this part anteriorly and then the lateral plate. Because this is a difficult plate again 2-3 times. So you can put on medial, you can put anterior, you can put lateral as well. So it was even the decision to put which plate out 3 is nicely done. So I think wonderful job. Thank you.
Thank you, sir.
Thank you, sir.
I also asked all the seniors my details. If there is a CRO of this gentleman, present is nominee of the segment infection. There are 5 states. What is the best option?
what is the best option of this management of this type of segment of please know. Yeah, right?
It's in your hand.
Second is the, what is second best, and this must you are expert.
Yes.
Okay, so next case is deformity of femur, and it will be presented by our resident Dr. Bilawal Hussain Sheikh.
Bismillah ar-Rahman ar-Rahim. I'm Dr. Bilawal Hussain Sheikh, orthopedic resident at Abdullah Muhammad Medical College, Sikar. I am here to present a case presentation. A 13-year-old man, Mr. Abdul Ahad, resident of Kherkov, presented to us with a complaint of pain thigh left for 6 months, difficulty in walking for 3 months. According to my patient, he was here in a state of health 2 years back. Then he got a trauma in which he sustained closed fracture femur left. Operated on the second day of trauma at a private hospital. Open reduction and plate fixation was done. Full weight bear after the 6 months. My patient complaining of the discharge from the wound after 1 year. Again, he operated with a removal of metal and biopsy done. Biopsy shows low-grade osteosarcoma. Then refer to the oncologist for chemotherapy. Now, patient presented us with deformity of left thigh. Deformity developed after the completion of the chemotherapy. It was progressively increasing. And deformity associated with pain and difficulty in walking for 3 months. My patient unable to perform daily life activities, and recent history of weight loss is positive. And associated history, all are the insignificant except the drug history, in which 3 cycles of adjuvant chemotherapy included carboplatin, ifosfamide, and the mesna. And examinations, general physical examinations, outlook is normal, left eye marked with scan, rest of examinations are normal. Vitals are within normal limits, sub-vitals are normal. On systematical examinations, it was unremarkable. On musculoskeletal examinations, my patient walked with a limping gait, and there is an anterolateral bowing of left proximal femur, and also the wasting of muscles of thigh and leg, and also foot in the equine position. My patient cannot sit with cross leg, he cannot squat, Tenderberg test positive for left side, no fixed flexion contracture. Movements and left hip joint are restricted and also painful. Around 4 centimeters of the wasting of left thigh. Apparent shortening around 8 centimeters. True shortening around 10 centimeters. Power, tone, reflexes are normal and distal neurovascular are intact. On local examinations, there was a swelling involving the proximal thigh around 15 centimeters in size. Normal in color, firm to hard in consistency, normal temperature, no any tenderness, margins are regular. It's the previous investigations, including biopsy, done on the 17th October 2020, that suggests a well-differentiated low-grade intramedullary osteosarcoma. After biopsy, patient was referred to the oncologist for the chemotherapy, where they advised the bone scan that done on the 23rd October 2020. Bone scan shows primary neoplastic pathology like osteosarcoma involving the proximal femur left with no distant metastasis. This is a recent X-ray of my patient, Mr. Abdullah, taken on the 8th January 2020, showing the anterior posterior view, showing left hip joint, proximal femur, mid-shaft femur, in which mixed type of the lesion involving in the proximal femur with not significant periostal reactions associated with fracture and femur lie in a various position called Shepherd's hook deformity, and also a remaining of the shaft of the screw. This is X-ray of my patient, recent. It looks normal. After a baseline is also normal. This is chest X-ray, CT scan, abdomen and chest. They're done on the 20 January 2022. Both lungs is normal. No any evidence of metastasis seen. Cystic lesion noted at the lower fold of the left lobe of thyroid. Further workup regarding the thyroid are remaining. Let's start the discussion regarding the management of my patient. No, sir. No any documented available before the chemotherapy. Yes, sir.
There are two osteosarcoma types where they look at the number one is low-grade osteosarcoma, number two is paracarcinoma. Some of the people think they don't do the chemotherapy in the neoadjuvant. Instead of go for the surgery and then even don't do the adjuvant chemotherapy. But that is for the people who are operating within due time. If somebody got the chemotherapy, there's nothing wrong with that. If somehow patient is getting benefit and disease is somehow reducing. So in our setup, we always consider neoadjuvant because we sometimes have biopsy problems, sometimes have variety problems. So we always consider neoadjuvant in our setup. So first always give 3 neoadjuvant chemotherapy and then plan for the surgery. See, there was some excellent results with neoadjuvant. These type of people have normal life because one of the aggressive osteosarcoma is life-threatening problem. But the neoadjuvant is so great. Parents osteosarcoma, these are very good. If you are able to remove, they have absolutely normal life, more than 10 years without any metastasis. So see, he came to you in October, okay, already 5 months gone away. In between he gets the chemo. Before he comes to you, at least 3 months more, he may be outside the hospital, right? Maybe roaming around. So around more than 1 year, there's no meds. And see, if chemo was given, and this is post chemo, see the chemo to the so see the chemo responding like night very. So these are good things that patient responding to the chemo is only localized to the bone, no extension to soft tissue. So this is something impressive. So you can do reconstruction in there, whatever you like. And is there any fixation was done in this?
Yes,
No
sir. Yes, sir. Previously fixation was done, sir. But DCP, sir.
See, this is one message I want to convey. Okay, once you see something pathological, don't fix. Don't put play. Don't put nail. We have concept, it's written in the table. Once you see pathological picture, put the nail. Now what will happen? That is for metastasis. That is for not for the primary disease. We have seen few of the very important cases where simple humerus fracture mid-shaft transverse and some very small lesion of 1 centimeter and somebody put the nail. So what happened? Within 3 months, all humerus disappeared. And low-grade osteosarcoma without doing biopsy or do the biopsy and then fixation with the femur, all femur disappear. So we have these kinds of patients. What we are seeing, even if they are serious. So what is the protocol in pathological fracture for primary lesion? So this is message for everyone because all our orthopedic we are aggressive to fix. And even if the people who are doing outside, they are doing the same. Either pathological put the same. So don't do that. So yes, sir.
primary molecular. Then we will go for X-ray.
Do nothing, do nothing. Follow simple protocol again, history examination and best investigation. You find out only the lesion, after all workup, there is no other disease involved in any other part. There's a fracture, okay, you apply Bacillus, and there's nothing to do other than Bacillus. Take the biopsy. Now, after doing all investigation, CT, test, MRI, do the biopsy. Once you're done with the biopsy, confirm the diagnosis. Now, say for example, that pathology fracture is also sarcoma. Give the patient chemotherapy. Now, see the response. If the chemo is responding to the fracture and fracture is healing during this 6 weeks, chemo is there, the protocol stable. From today, you will start 0, then second dose on 3 weeks, third dose on 6 weeks. So, within 6 to 9 weeks, you will complete the chemotherapy. And if you see the fracture healing, that is showing an excellent response to the chemo, and that limb can be saved. Now, if you put some implant, it means you have done everything. Now it will be amputated, whatever the response of the case. So this is the message. Don't put implant. And if you put a fixator, say for somebody who has a mesothelioma mid shaft, you will put 2 pin distal, 2 pin tape, and that is the aggressor. And it's not responding to the chemo. What will happen? Somehow it will involve the pins and dissolve. And again, it is a problem. Your top it will be contaminated. So simple fact is, for 6 weeks, we are putting for 6 weeks. Okay. So to keep the pathological sample, just apply it. Don't do anything. Don't put any implant inside. So we have this series, which I will show you a very interesting case where I think it's very simple. Put 2 issues there, no problem. It's very simple. Put nail. There is something very disastrous and life-threatening. And I've seen the patient who died with the treatment. So this is excellent response to the chemotherapy. So see, there's deformity only, but there is problem of chemotherapy scroll. So you can have multiple options or reconstruction.
It is best to rebiopsy to decide for the coverage.
No, there's no need of doing revive. A normal bone with femur will take 6 weeks. It's not possible. But you can see some callus in there. For the pathological fracture, there are pathological cells there. Along with normal cells, there are pathological cells. So the pathological cells respond to the chemotherapy. So they showing that this tumor is getting reduced, that is growth again. The tumor reduced. So हम उसको देख के decide करते हैं कि tumor की size कम हो गई, the swelling कम हो गया, patient का pain कम हो गया. That helps in all these things के भाई this is responding.
एक बार बैठ के करते हैं एक obviously करते हैं बताया कि temptation to fix जो है ना उसको hold करना है. We have to hold ourselves from fixing. और उसमें there are ways of managing. जैसे एक backlog लगाकर आप बेड स्ट्रोक को प्रिवेंट करने के लिए उसको बताएं कि आप कैसे मूव कर सकते हैं. एंकल काउंटिंग को बताएं कि आपकी टीपीटी प्रिवेंट करने के लिए. तो ये जो आप एनालिसिस को प्रिवेंट करने के लिए जब तक ये वो बेड रेस्ट पे है and we are planning for that. Second thing is that this is very important कि biopsy कहाँ से कर रहे हैं. Biopsy scar को अगर malignant tumor है, we have to be removed with the final resection. तो अगर आपने प्लान किया हो कि मैं इसको anterior resection करूँगा biopsy इसमें पीछे से की हुई, अब वाला से काट देना नया प्रॉब्लम है, फ्लैश का मसला बन जाता है. तो biopsy इसलिए जनरल में ये बात लिखी हुई कि biopsy should be done by the person who has to be do the final resection. इसलिए इसमें डॉक्टर साहब कहते हैं कि अगर डेडिकेटेड कैंसर सर्जन उसको रेफर करें ताकि बायोप्सी भी वो ही करे ताकि उन्हें रिकंस्ट्रक्शन प्लान के हिसाब से बायोप्सी. तो दिस इज वेरी इंपॉर्टेंट. और दूसरी बात हमारे पास बायोप्सी करने के लिए जो नॉलेज ना तो शुरू में कुछ नए हैं एंड एक डायरेक्टर बैठे हुए बायोप्सी करने के लिए ना एकदम हो गया वो एक एस्टेबलर लीजन थी एंड मैंने बायोप्सी जो है ना वो हमने कोशिश हार्ड से कर रहे हैं. Later on, I learned that I will contaminate the whole effect of muscle by opening it up.
So there are deeper tissue violations हैं, bony lesions, उसके लिए there are covers available, especially because आराम से मिल जाते हैं, so we can go in with minimal disturbance of the soft tissue and the muscle, और उससे हम biopsy करें अगर करना है, जो भी करना चाह रहा है, it's not necessarily a biopsy technique.
In fact, for this is challenging case for management is concerned at present. He has gross deformity and shortening about 4 inches. So the patient's relatives are worried for a deformity as well as shortening. So we'll go on discussion for that in a while. Mostly I have seen in my experience that the Leon's pathological fracture, Leon was so small that after fracture at that side is not visible on first X-ray, which are done mostly in the government sector. So people don't know whether it was pathological or not. They, in the children, they mostly think it is an simple cyst. When as in a teaching, standard teaching is when there is even you suspect simple biopsy at the time when you are operating. So somebody operated, he has probably that was missed or overlooked because of not good quality of the X-rays. That was fixed in a plate, which she got loosened, and that was removed at the time of removal. Probably biopsy was done, which came as become a regularly low-grade osteosarcoma. And luckily it has healed. We are thankful to Professor Badar Saab for his experience and advice, nice advice, current concepts, that has now united. The problem what at present the patient has is this gross deformity, and they are thinking as it has recurred because there is big swelling due to deformity.
Yes.
One, whether we should rule out whether it has recurred or not. Secondly, how to correct the deformity, correct the shortening. This is the real problem at present for the patient.
Basically, again, if you leave the tumor, it's responding good, but it recurs again. So exactly, you are absolutely right in saying you confirm either the recurrence or not in the top. So do the MR first, remove this, maybe this will create a
Yes, sir.
problem.
Yes, sir.
The chances
So
are
that's why I'm not indicated, sir.
So you can remove it to the MR because if you have cleared the item of the soft tissue, you can remove for it. So and getting definitely you will just see how it will. Now there are too many options in this. Because once you do MRI, now my priority will be first priority will be either I can save this head and neck great trochanter or not. Now this is the first priority. And second, I will because if you save this part, so you can have native hip, you can have native great trochanter, and if you put into the valgus, so at least 3-4 centimeters you will correct this shortening with this only. And if you remove this bone from here to here, see this is low grade, and if we can do recycle with this, number one. Number two, we can put some fibular graft in this. Number three, we can put intramedullary this is what we call intracapillary mega processor. So number four, we can put laser. All options are available. Now either you want to save the hip or not. If you don't want to save it, remove, put some processes. There's again an option. So there are too many options. So this child, always we try to save the hip. Always we try to save the hip because this is possible in low grade osteosarcoma, and even in this case we can have clear cut line. We see this, we can save the great trochanter right and trochanter area. But key is to see again MRI first. Delineate your plan. Keep all 3-4 options in your mind. What will be the best available in your theater? Then you can do it on this.
Again, repeat MRI and save the hip joint, resect the subtropium or intertropium, and resect the wide section of the lower end of the tumor, and put a laser. The laser expert is here. I think it will be help to the patient.
Thank you, sir. So this was again a very good discussion on a very good case, and clear message is that we should not fix the pathology structure until we have biopsy. Thank you. Next case is from CMC Larkana. Dr. Nasir Manzoor will be presenting a case of ankle deformity.
He was treated by Boone Sitter with multiple plasters, bandage, and massage. After that, he had painful ambulation and a bed tear.
For last 6 years, he feel difficulty in bathing, which is increasing and associated with progressive painless deformity of left ankle. He then sit and spew, but feel difficulty in running and choose the earth. There is a no associated pain, swelling, fever, and weight loss history. Systemic review within normal limits, birth history, NVD, normal milestone, past medical and surgical history, unremarkable. Vaccination history, my patient was fully vaccinated. Personal history, sleep and appetite is normal. No history of reduction. Family history, he has one sister, 2 brothers. Parents are alive. Among them, no chronic muscle skeletal disorder. On general examination, a young male of average height and build, sitting on chair comfortably, well-oriented, time, place, and person. Vitals and sub-vitals are in normal range. On low this is the clinical picture showing on low patient limping there, and there was a healed mark star present front surface of left knee and various deformity of left ankle and left malleolar bones are prominent. On low patient limping there, healed star mark on front surface of left knee, various deformity of left ankle, bony prominence at left lateral malleolus. On field, temperature around the ankle is bilaterally comparable, no tenderness around ankle, dorsal pedis pulse bilaterally palpable, no lymph node enlargement, sensation around the foot and ankle is normal. The lazy test positive for tibia, middle malleolus is small and irregular, while lateral malleolus is deformed and prominent. On movement, all movement active and passive are slightly reduced, dorsiflexion up to 50 degrees and plantar flexion up to 30 degree, inversion up to 20 degree, and eversion up to 10 degree, and 2.5 centimeter true shortening and 2.2 centimeter vesting of left calf. Various undulation of 35 degree and muscle power is 5/5. Lab investigation, all lab investigation are in normal limits. And this is the plain radiograph of slightly immature person, AP and lateral view showing the left side femur, knee, tibia and fibula. The positive findings are there is a malunion of middle malleolus with a progressive progression with epiphyseal growth arrest, which causes various deformity and deformity of distal fibula with physeal opening. This is the summary of my patient, a 60-year male with limping head and progressive deformity of left ankle, and on left side there is a clinical and radiological picture of the patient.
So, what is your diagnosis?
Sir, my diagnosis is patient suffering from post-traumatic epiphyseal injury, which lead to the various deformity of the ankle.
What kind of injury?
Yes, sir.
What kind of injury?
Post-traumatic, sir. Epiphyseal.
Post-traumatic.
Yes, sir.
What type of post-traumatic injury? Which type? Which type?
In this patient is suffering from, sir, according to Center ALS type 4.
Type 4.
Yes, sir.
Now, what are the only deformity or pain? What are the complaints?
Patient have only a deformity, sir.
Only deformity,
Yes.
no pain.
No, sir. Without pain. No complaint of pain, a fever, and associated. Sir.
So, question to audience from the inside. So, patient having no pain, only deformity.
That's it.
Now, the issue is deformity is the
That's it.
physeal injury, there is Schalter has type 4. And there is a valve deformity, it's about 15-20 degrees at around ankle. And there is a decreased joint space in the tibial joint. Any surgical option, you cannot achieve the articular surfaces. Only you have option to correct the deformity. You cannot prevent the arthritis of the joint. Only you correct the deformity.
Because if you don't correct the deformity, the arthritis will be earlier. Then this is the reason you need to correct the deformity. You need to correct the deformity.
There is an indication of the deformity correction is that it's around 10 of the deformity is biased more than 10 degrees. It is indicated. You always correct the deformity. But after the correction of the deformity, do you think you can prevent the arthritis in this patient?
Yes, by maintaining the normal alignment of the ankle, you can prevent, because 1 mm of angulation in the dome of this ankle will decrease the surface of the tibia over the talus by 45%. And increases the chance of arthritis. So it is to correct the deformity to prevent early arthritis and later on, because this young guy, you give the chance.
There is no doubt. You always correct the deformity. This is indicated. There is no doubt in this that you will not correct the deformity. The problem is here.
What is the age of patient?
This is not problem. This is the thing.
Now, what is this is the Schalter
I
type.
can provide him a good support because this looks like a middle miller.
Yes.
Okay, this is defect. Don't do anything with it. Just do supramellar osteotomy with whatever the method you use. Don't supramellar. So that will correct the alignment of the ankle. Once the alignment is corrected, that will definitely help in decreasing the chance of osteoarthritis. So if you leave it,
One more thing.
There is no doubt you always maintain the mechanical axis. There is no doubt.
I think
You need deformity correction, no doubt. in
Dr.
this.
Zamir will.
The second is there. You think this articular surface escape off. It is about 1 centimeter. Only only we can correct the deformity, we can further prevent the arthritis in later on. But it will always causing the arthritis. You always counsel your patient. The thing is that you always counsel your patient in future, you may develop arthritis because of the physical injury. We are only correcting the deformity to achieve the mechanical access. You can walk comfortably. In this deformity, you cannot walk comfortably. For the comfort of the patient, we are correcting the deformity to maintaining the mechanical access from hip to ankle. But this is not surety that there is no arthritis occur later on.
But at the moment, I thought you
At the
are
moment,
right.
yes,
At
yes.
the moment, you are very right. At the moment, where the only option is to correct the deformity and maintain the axis.
Yes.
If in this axis, if the patient is walking, he will develop arthritis early.
Yes.
And after making his alignment normal, so why he develop the arthritis late? At the moment, only option we have is to correct the mechanical axis and do correction either gradual or acutely. And where is mechanics, then we have problem is whether he is going to develop after correction of his axis, the arthritis or not. But at the moment, only option we have to correct the.
Second, for the exam point of view, you always counsel your patients for future, for rehab. This is the exam point of view. If you are only correct the deformity and you are not explaining and not counseling the patient and family, and later on after 3 years, 4 years, the patient came to you that I have pain in my ankle, and you did my surgery after about 4 years ago, and you never told your patient about the arthritis. So always counsel your patient and family regarding the deformity and regarding the arthritis.
Sir, one more thing to add. This patient may be presented in a PD only with the painless deformity. It's not that and patient was very anxious about its deformity. He has two events. This patient was counseled, that patient might develop, arthritis in the future. If we are correcting only the deformity, we are not touching the axis. So this was all counseled to the patient, and the chief complaint was on painless deformity. If patient had pain, we might have another option.
So these are the treatment.
Sir, I fully endorse the opinion of Professor Badar Saab, also support the idea and advice of our young surgeons. This patient needs definitely promalleolar osteotomy of Punas. As long as you just do promalleolar osteotomy of tibia, it may not be possible to fully correct, and also do the osteotomy of tibia. And secondly, in the future advice or warning or counseling to the patient is that he will definitely in the age of growth spurt. In male, it is 16 to 18 years, major length of the height is achieved through bones. So this patient is likely to get recurrence of deformity and osteoarthritis to some extent, as well as shortening. So you have to advise counsel the patient of three future happenings. So please continue.
So these are the treatment options. The regular correction of deformity with alizero fixation and therapeutic osteotomy and internal fixation and ankle orthosis. These are the internal ring fixator assembly. Fixator device which are assembled by 3 rings and placement of motors and hinge at proximal to the deformity. The M was to treat the regular distraction and lead to correction of deformity and length equalization of the patient. So this is the post-op X-ray in which various deformity are corrected and osteotomy of tibia and fibula both are done by the professor. So this is follow-up picture of this patient. And sorry, These are the clinical picture of the patient, sir, on follow. Within 2 months, sir.
There is one thing, the correction of the health patient. No arthritis that we because the infection will be in the family, we will also develop the early arthritis that we need.
Again.
So this patient has definitely benefited from this, excellent outcome.
Our next presentation is Dr. Azizullah Bhayo, Assistant Professor of Ghulam Anwar Medical College, Secretary, and he will present an overview of services being provided at GMC Secretary.
Thank you. Bismillahirrahmanirrahim. Thank you, Dr. Sajad. I am Dr. Azizullah, working here as assistant professor at GMC, and I will present briefly the overview of procedures, and these are being done here at GMC department, and these all things are all the procedures are dedicated to our teachers, especially our Professor Sadullah Sahab and Professor Shahid Sahab, Professor Zamir Sahab, and other my teachers who are not present here. At GMC, with the support of the professor and principal of this college, and is also the chairman of hospital management committee, that all the implants for the trauma procedures and for the arthroplasty are being provided free of cost. So at the GMC, there's no any single rupee or penny is being got from the patients. All things are done, all the medicine and implants free. So this is the X-rays of fracture elbow and complex fracture that was reconstructed with the bicolumnar anatomical locking plates. In other case of the comminuted fracture of the distal tibia that was fixed with the locking plate, distal medial locking plate with the MIPO technique. These are the post-op X-rays of the elbow reconstruction with the small fragment plates. And then other case of the MIPO technique, that was the highly comminuted injury. You can appreciate on the X-ray. And in the pediatric population, we use the elastic nails in the pediatric long bones. And in other case of the clavicle fracture hook plate. And this is the case of 45-year-old young man. That was the segmental fracture femur, fracture neck, the cervical neck of femur and the shaft of femur. That was fixed with the EFNA. Close reduction was done, and has our team working with us at GMC. These are the on the right side fresh X-ray after the second day of surgery, and then the next X-ray you can appreciate the unit on both sides, at neck and in the shaft. This is an other case, the complex injury, highly comminuted fracture at the IP and ST level. Patient had already also the arthritis. He was young patient, so we opted first for to save his head. This was PFNA done about 1.5 years ago, and now the fracture has united and patient is mobile. So on this particular case, I will also like one comment from our Professor Syed Shahid Noor Saab, that he was a young male patient, and we tried to save his head. So, so 1.5 years back, and recent X-ray, these are present with me in my mobile. I can show you. The fracture has united and patient is walking, comfortably walking.
Okay.
Yes.
In that case.
So
it is fine.
we are taking your expert opinion in retrospective, that whether we decided to save his head, that was our decision was okay, or we would have gone for the THR.
Back to basics, history and examination and investigation.
He's a 25 years old, so young patient.
What was the mobility and pain from his left hip prior to injury?
Sir, he had a mild type of the pain, and he was happy with that life. And he also himself said that if the fracture is uniting with the surgery and I can go with in the same position, it will be I will be happy with the surgery.
Then, so there is no one solution. It is the discussion with the patient that we have given him the option of arthroplasty and osteosynthesis. Now, 1 year down the line, 1.5 years down the line, we've said that his fracture is united, and he's happy.
Yes, sir.
That's so you're taking a correct decision, and obviously this arthritis is not going to disappear, but I think this is a message to the audience and participant and people who are going to appear in the exam, that you always discuss with the patient, and there are always more than one option. Many cases presented in this meeting today. Number one, very nicely presented, and I must congratulate the whole team of GMC of wonderful presentation. Message to the resident who are going to appear in the exam is that there are more than one option, and the final decision is after discussing with the patient, giving pros and cons of each option.
Thank you, sir.
So, right decision.
Thank you very much. Distal femoral locking plate in the supracanal fracture femur and bipolar hemiarthroplasty. Deformity correction and Elizabeth services has been started from 2008 when the Professor Zulfikar Ali Sumo joined this department as assistant professor, and these procedures are now being done regularly at our department. The deformity patient presented with the malunited tibia and the deformity that was corrected and Elizabeth was applied. This is the case of infected non-unit that was operated at our department. So our team with Professor Zulfikar. And arthroplasty services are also was started 1.5 years back here. So this patient presented us with the AVN with the arthritis hip, and the total hip replacement was done It was also free of cost totally at our department. And we are also thankful to Professor Zamir Aman Saab and Professor Jagdesh Saab and Dr. Saifullah Sundur Saab, because they also remain with touch to us. And in one case also Dr. Saifullah came here. And this is another case. This patient presented to us with the bilateral avian and bilateral PHR was done. This is the picture of the patient sitting, and the picture was given with his consent. He's walking pain-free and happy. Painless. There's a painless, pain-free. And pediatric orthopedic services are also given here, and we are thankful to our teachers. PMR, tendinoepiphyseal lengthening, and other corrective osteotomies for the foot are also being done routinely, and DDH surgeries. We operated some cases of the DDH here, and one workshop of DDH was done by Professor Anisuddin Saab. And after that, we have continued. For the tumors, benign tumors, resection and reconstruction, few cases we have operated here, fibrous dysplasia, curettage, and tubular grafting and cancellous graft with flexible nails. This is another case of the aneurysmal bone cyst. Patient presented with the fracture, and age of the patient was about 14 years. Curettage and the fibular graft was, and it was fixed with the DCS. So you can appreciate the fully union on the left side. So thank you very much. This was all about the overview of the cases. And we all faculty are thankful to our teachers. Thank you very much.
Thank you, Dr. Aziz. And now the next case will be presented by Dr. Junaidur Rahman from Calcutta Medical College, Latkana. It is case of non-union, and I don't know what non-union, what point.
Assalamu alaikum everyone. I am Dr. Junaidur Rahman, PG, Orthopedic Unit 1, Calcutta Medical College, Latkana. So today I am here to present a case. A 42 years old male, right hand dominant, presented to OPD with complaint of severe pain in right arm, swelling of right arm, unable to move right arm for 7 days. According to my patient, he was already 4 years back. After that, he fell from height of about 10 feet, developed severe pain and unable to move right arm. He was brought to orthopedic department, Civil Hospital, Latkana, where patient was optimized and diagnosed as case of closed fracture of right humerus. At hospital, open reduction and internal fixation with DCP was done. Patient was all right after that. After 6 weeks of operative intervention, patient developed pain at operative site. Pain continued for 4 years, on and off, for which he was taking analgesics. Patient was non-compliant in follow-up. Now 7 days back, he again fell from bike while driving. Then developed severe pain and was unable to move his right arm. After that, he was brought to orthopedic department of Civil Hospital, Larkana. Past histories, there is no surgical or medical history of significance apart from open reduction and internal fixation BCP for right humerus fracture. Personal history is he is non-smoker. Sleep and appetite is normal. Family history he is married and that is also insignificant. Systemic inquiry is insignificant. Socioeconomic, he is shopkeeper by occupation, belongs to middle class family. Clinical findings were GP general physical examination was unremarkable. On inspection, there was swelling in right arm. Previous surgical scar was present on anterior aspect of right arm. About 12 centimeter long, non-tender, non-adherent to the bone, no discharging sinus. On palpation, right arm was tender, distal neurovascular status was intact. Movements there was palpable crepitus. So this is the first X-ray of skeletally mature person showing AP and lateral view of right humerus. Obvious finding is short oblique fracture of proximal shaft of right humerus. U-slab is in place. So this is immediate post-operative radiograph of this patient. BCP was done with a stable fixation. After 2 months, this is plain radiograph of this patient, a 2 months follow showing formation of callus and implant is also stable. After 1 year, there was increasing gap at fracture site and osteolysis and loosening of screw around distal edge of plate. A 2 years followed radiograph shows implant loosening and gap at fracture site with obvious deformity. Now this is the present X-ray. The present radiograph showing implant loosening and stress fracture at distal end of BCP. These are lab investigations. These are recent lab investigations which are within normal range. Hemoglobin, WBC platelets are also normal. Patient is non-diabetic, having RPH 136. Kidney renal function is also normal. As urea and creatinine, these are also within normal range. Viral markers were negative. And ESR and CRP are also normal. Case is open for discussion.
Next question from you. As you saw the first X-ray, the first focus of the tape of X-ray, what was the problem in that X-ray? You think, is there any of the problem in the very first X-ray was there? Can you appreciate something in that X-ray?
Actually, there isn't appropriate compression at the fracture side. I would say that. Otherwise, I don't see anything.
Or anything from the audience? Water waste? Go back to the very first X-ray.
Yeah.
What is the problem in this? You're right. Operation is not that much adequate that the effect can be compressed on that. What else problems can you see?
I don't see anything. I will.
Yes, good.
I think we have done it correctly. First of all, after that.
Which implant? Is it good for this universe session? Which implant?
What JCP is that? Narrow, broad, mini.
This looks to be a narrow.
Yeah.
Narrow DCP.
So when you're applying a plate and you're putting some that plate in the compression, right?
Yeah.
So what kind of union you want to achieve? It should be a primary fracture union or it should be a secondary?
It should be a primary.
Yes, it should be primary, right?
Yes, sir.
So go to the next X-ray, you will see some callus is formation is around.
Yeah.
So why it is callus in the primary union of the fracture? There is no any sign of callus there. So what could be the reason of this callus?
being around that region.
But there was affected, like only the illness might be arising from that idea too. One more thing.
Normally, normally, I don't know this is how. Yes, flag can be brought, that is something different. But that is okay, what's wrong? They can put some water, nicely done.
So, it is very nicely done. And he was saying the same thing after. Okay, so in this time of too much, there will be a lot of problems. The patient might have a patient might take so there should be sort of thing. You see, immediately after the reduction and operation, X-ray looks good, and this is takes after 2 months. So within a time of 2 months, patient might have gone for with low grade infection, any other. Okay, so there is no issue in this.
So, just very well done, case, one thing. But what we are doing over here, we just want to understand why it didn't have this healing took place, why it failed, right? We are all here just to have a discussion. We are not here to provide that badly, it is perfectly fine. Why it happened, that's something like, I want to learn, I want to understand. This, if you go to the next axis, see what happened now. So then go to the next axis. So there is a hypertrophic non-union. We all agree with that. Why there is a hypertrophic non? What's the basic concept here?
It is stability.
Because of the mechanical cause. It is nothing like because any related to the body. It's not a post related. It's basically what is happening, the implant which is being applied, it doesn't provide the stability. One thing. Secondly, humerus, there if you see the bone, it is not straight like a DPI. It is rotated. The rotation is because of the multiple directional forces which is coming on the humerus from the multiple muscle, which is causing it to have pulling and pushing forces from here and there, which need to be overcome so that the healing could take place. So, if in humerus, my thought is rod PCP with the hole at a different aspect, we're going to give it a more good mechanical support, its stability, and then we're going to do it to heal. So, surgery was done perfectly, concept was placed, but the mechanical force were not able to overcome, and there was a hypertrophic scar. That's basically what. So now if you see because of this multiple forces which has happened at the bone, there's the screws have loosened, the holes have increased, there's a very you can say implant fracture. So first of all, as you said, try to rule out the infection that we all will do. In my point of view, what I will I will remove the implant. I will make sure there is no infection, histopathology, and to see the at the same operatively. And I would rather go for a nailing. That would be something I was going to prefer in this case, starting from the proximal and we're going to go to the distal, so that my whole of the tissue of sleep or the soft tissue has been minimally eroded from the bone, preserving the periosteal blood supply. That's my at this moment I am going to talk. And of course, it is open. I will go to the bone graft also. If anyone has any other aspect, so we can talk about.
That's right. It's right that we have to do the fixation. First of all, we have to rule out the infection, and the inflammatory markers are normal, but again we have to coincide the whether the bed is infected or not, and what sort of tissue can be taken for the histopathology and also for the sensitivity. And if you are going in and seeing there is no sign of infection, you can put the bone graft and you have to fix with but we have done this surgery, and when we opened it, so the middle segment, which was looking, it was just a hollow shape, nothing was there. So then while putting nail, it was looks to be just a shell. So I again set up broad DCP with the tubular graft inside the shell of the bone, and there was no sign of infection inside. Okay, and also did the cancellous bone graft on the both sides. That was what we have done, and assumed that we to the right and protect the sling.
The implant that you use that morning.
This is the yes.
So see, again, mechanical stability, we have to focus, understand why it failed. It's mechanical or due to the force related. If it is oligo-nonlinear, if it is atrophic nonlinear, then we have to see related to the patient itself, there might be something. But if there's a hypertrophic nonlinear, so you have to understand why it is hypertrophic. Mechanically, it's not stable in a two-battery. So now it is perfectly placed. It is a broad display that is being used, and inshallah it will be nice.
The message here is that it's not a simple case. So freshly passed MSS, freshly passed MCPS, no jump on it. It is there are more than one ways of dealing with a problem. First thing is understand it's a simple, complex, or challenging. I would say it was a challenging. And there are more than one way of dealing with it, of achieving the target. Yeah, success aane ki kai raaste hain. Yeah, nothing. But as long as we come here, we came great, so we are sorry. Okay? लेकिन सटर पहुंचना मीटिंग अटेंड करना ये हमारा एक एम. I could give a suggestion. I'm not a very experienced promoter. I would have preferred to put a bigger fibular graft. So the fibular graft is at this segment, but if you could have used a larger fibular graft going into the proximal fragment and distal fragment, that would have given additional stability. And rightly said by the cancellous graft. So mechanical aspect has been corrected by changing from a narrow DCP to broad DCP, which according to Martin has said, it will provide mechanical stability. But if the biology is not corrected, mechanical is going to fail. So once the biology is corrected and by bone graft, calcium, vitamin D, or whatever supplement you give, once it's healed, so difficult and challenging has to be done by experienced person and has to spare time, freshen up bone head, leading it, take time because people are racing nicely done as we move, and inshallah this is going to be nice and patient.
I comment one thing. We were sure, Lokesh commented that ignorance is a medical force. Okay, because sometimes the simple pressure passes, nothing wrong with that, and you will have a disaster. So do the first time in appropriate way so that you can use it in a simple way. And to treat non-linear ignorance is again not a simple as I said, it's a real challenge. So sometimes you have
And the implant not available to put into the neck. Sometimes you don't have expert to bend this plate and to put the two into the neck. So sometimes you need to plate all the humerus. Sometimes you need to plate two plate. So sometimes they tie up the put all the humerus because middle segment is not there. So it's not that simple. It's something very challenging to operate on non-humerus.
हमें ये कंक्लूजन करने चाहिए कि सिर्फ बॉटम प्लेट आपका प्लेटिंग इज नथिंग proper and biomechanics what you are using in this and almost the humerus is notorious for you अगर इसमें थोड़ी सी भी गलती हुई आपसे ये यूनाइट नहीं करती तो a simple plate broad BCP well placed alhamdulillah.
दूसरा ये कि अगर चक्कर आने का रास्ता पता नहीं है तो किसी से पूछ ले। Okay, thank you. So next case is bilateral hip pain that will be presented by Dr. Sohail Haider Ansari. Sohail is also a resident at GMMC and he is the second one to join us. First was Bilal who presented earlier and now we have two more that are sitting behind and inshallah they will be presenting in next meeting.
Thank you. We all love him. Thank you, sir.
Should I? Assalamualaikum everyone. I am Dr. Sohail Haider Ansari, resident orthopedic, Ghulam Mohammad Medical College Hospital, Sakkar. Today, my presentation topic on case presentation bilateral painful hip. Here we start. A 27-year-old male, Taylor Master Ghulam Farid, resident of Sakkar, presented to us with a complaint of right hip joint pain and left hip joint pain for 6 months and difficulty in walking for 6 months. History of presenting complaint of my patient pain started in right hip 1 year before, which was insidious, dull and constant, increasing in severity over time. Similar pain started in the left hip 6 months later. Difficulty in walking, evening paralysia, consulted to the private hospitals where he was diagnosed with a tuberculosis and took a treatment for that in 9 months. There was a partial relief on ADT and later consulted to the traditional healer at the medication for 3 months, but there was no relief on that medication. Now pain is severe, disturbing in his ability to walk and perform his routinely activities. Past history, patient took ATT for 9 months, family history and personal history, non-significant, socioeconomic patient belongs to the poor class. Examination, general exam, physical examination, vitals within normal limit, some vitals patient was anemic, others were normal. Systemic examination was remarkable. Musculoskeletal examination, stand with the left-sided pelvic tilt and left knee slight flexation. Cannot sit or cross with the cross leg, cannot squat. Penderberg test positive on the right side. Range of motion of the right hip decreased. Abduction up to the 25 degrees centigrade and internal rotation up to the 15 degrees centigrade. The rest of the motion of leg was normal. There were 2 centimeter wasting of the right thigh, apparent shortening about 1.5 centimeters and 2 shortening about 3 centimeters. Power tone and reflexes were normal. Range of motion in both knees, at both knees and both ankles were normal. Range of motion at spine was decreased with the decreased extension up to 10 degrees centigrade. 10 degree. So what could be the differential diagnosis? TB relapse of TB and multi-drug resistant TB, avascular necrosis, due to the idiopathic or rheumatic arthritis or ankylosing spondylitis. Here the investigation we ordered, patient HP was 9.8 gram per deciliter and ESR and CRP both were raised. Here the X-ray of ground parese plain view shows took on 27/11/20 shows there the narrowing at the right hip joint. Here the full pelvic X-ray of ground parese shows the complete augmentation at the left hip joint and the right upper narrowness at the right hip joint. And there also is the obliteration at the sacroiliac joint. MRI scan suggests the both bilateral avascular necrosis of the head. So, diagnosis, what would be the diagnosis on the basis of history and labs? And treatment, what discussion about the treatment?
Yes, sir, it's the.
Yes.
And the diagnosis, like, so in all inflammatory markers are high. You don't have a definitive diagnosis, it's an assumed diagnosis. First of all, I think we need to confirm the diagnosis. And pulmonary tuberculosis 9 months is acceptable, but I think for musculoskeletal, it needs to be given more. And how compliant the patient had been in taking the anti-tuberculosis medication. So I would suggest do a head biopsy and start anti-tuberculosis treatment again if the diagnosis is confirmed. We don't have to wait for completion of anti-tuberculosis treatment. And once the diagnosis is confirmed and anti-tuberculosis treatment is on board, then we can proceed with the
Confirm about it first for that. All the markers
yes, I agree with
so do HLA-B 27, do RF vector,
Yes.
exclude other effectors.
So if you see the spine, what I can see over here, it's not so clearly, it's more little bit like sacroiliac joint, it doesn't say, it is being obliterated, it's being fused, right? And the spine, if you see the almost like, can you tell us about the range of motion of the spine? How much is the spine?
Yes, extension decrease.
So 27-year-old male, with this, all this, first thing, it should be the imbalance spondylitis on the list.
Yes.
You have to rule out it. At the ESR 100, there are three differential diagnoses. One is multiple myeloma, ankylosing spondylitis, and other issues, tuberculosis. So over here, as sacroiliac joint is obliterated, a very good clue for the ankylosing spondylitis. If you see the spine, what I can see, the whole space is obliterated. So that's more related to the ankylosing spondylitis. We have to rule out it with the help of HLA-B 27. That will going to give us the idea, then come to how to address the hip joint. And that's
even so let's do brief phrase.
Yes.
Once the diagnosis of ankylosing spondylitis is established, then he needs to be seen by a rheumatologist. He needs to give steroid and disease-modifying medication, and biological agents are also available. And then we need to see the response of steroid and disease-modifying. And this is going to slow down the process and see the response. So the message for this case is establish the diagnosis first, give non-operative treatment. So not all painful hip are TB. So this is a learning experience from this case. And sometimes if you don't understand, go for the diagnosis. Don't just give empirical. So this patient might have wasted 9 months and 12 months and 14 months having
had multiple antituberculous treatment inappropriately. So make a diagnosis, do a HLA-B27, do a CT scan of the pelvis to see psychoarthritis, get a rheumatology opinion if ankylosing spondylitis is confirmed, then the rheumatologist is going to start short-term steroid, disease-modifying medication, and there are biological injections available in Pakistan that is going to slow down the process. The patient remains symptomatic once the diagnosis is established, and in 3 months' time, the symptoms are not relieved, then appropriate treatment will be appropriate.
Yes.
If जैसे हम पढ़ते हैं ना कि single joint pain, so we put our 3 diagnoses. Number 1 is tuberculosis, number 2 gout, जहाँ हम अपने स्टूडेंट भी पढ़ा रहे हो. Okay, number 3 some of septic infection or maybe tumor. So these 3 common reasons whenever you feel one joint pain. But in our society and in India, where this tuberculosis is endemic, it is a big problem. We always think about it. If you don't think, it will be disaster. There are too many patients we have seen tuberculosis in Taylor, we have seen tuberculosis metacarpal, seen in calcanum, seen in clavicle medial, seen in lateral, seen in clavicle, seen bilateral. If we present the case, we did the total hip, both were tuberculosis. So see, we can do some mistakes as well because we say, okay, there is no tuberculosis. Yes, this can happen. So this, what is the common? To keep the person calm. But see, in ankylosing spondylitis, there can be lung fibrosis. Okay, so key simple X-ray and see this is just evidence on that definitely tuberculosis is absolutely wrong. And we started tuberculosis. This is again absolutely bad habit what we think we have. Okay, so we should consider always think about other problems. Yes, sir.
Very good discussion from senior most persons, and orthopedic surgeons and professors. General, after having this information, we all agree it could be ankylosing spondylitis. We have to then confirm. What the explanation of bilateral avian, what I think, he has been under treatment of many doctors and orthopedic surgeons. Definitely, he might have had got cortisone in that period, and that might have given avascular necrosis. Therefore, there is MRI finding of bilateral avian. So, usually, in ankylosing spondylitis, there is no avian, provided cortisone is given. Secondly, it's rare to have bilateral symmetrical tuberculosis in both joints, but as being endemic in this area, as Dr. Badr said, we have to keep this as a disease, as bilateral disease. But first diagnosis at present is the ankylosing spondylitis. We have to confirm it. Now, when to operate? And I would again request Professor Shah to give some comment on it.
So to summarize, first we need to establish the diagnosis. Once it is ankylosing spondylitis, start disease modifying medication, give a steroid, and see the response. If it's still painful, go for total arthroplasty because in addition to the joint arthritis and space reduction, there is AVN. If it is diagnosed to have tuberculosis, then restart disease modifying antituberculous treatment. Make sure that it's not a multi-drug resistance thing. In 3 months' time after starting antituberculous treatment, we can go for total arthroplasty. That's the international recommendation. Compared to septic arthritis, the Mycobacterium tuberculosis does not produce biofilm. The biofilm is a major disaster with septic arthritis and implant we have to eradicate. So, tuberculosis does not have to be eradicated. We can do global replication and continue with antituberculosis.
Thank you, sir. We actually had two more case presentations after this, but we are nearly approaching the Friday prayer times. So we are ending the presentations here. And after this, there will be a short Ajrat presentation ceremony, and then we will conclude the session. So before concluding, I would like to thank Mr. Saad, who has been with us since 8:30 a.m. in the morning. And all this session was telecasted by Zoom and live on Facebook. So thank you, Saad. You can sign off now. And we are proceeding further.
Thank you, sir.
Lights on.